colleagues, ladies and gentlemen. But before I begin, I first concede to Professor Ong that whatever he said, I totally accept. And I totally concede defeat that he is in the right. However, he's in the right as per the Old Testament of the Bible. This is the old teaching from the Old Testament he's talking about. This is focal therapy as it pertains to the old way of doing focal therapy. Behold, I stand before you, John the Baptist, telling you that in the New Testament, I now bring forth the Messiah for prostate cancer. And this new focal therapy will win over your arguments, Professor Ong. And with that, I will begin my talk for this morning with your kind permission. Now, I will confine my talk to MRI TULSA Pro, which is the latest focal therapy available today. It is the mother of all focal therapies. I will convince you by the end of this session, or I have to hang myself outside. Now, what is the contemporary basis that we have talked about? It is the second leading cancer in men in the world. The curability test for localized disease is about 90%. Sensitive screening cannot discriminate between life-threatening and indolent forms of the disease. And rightly, as Professor Ong said, more than 90% in the current Old Testament chose for whole gland removal, radical removal, which is the only way to get rid of everything. Really, I consider to that. And conventional treatments are good. However, erectile dysfunction, urinary and bowel complications are very high. And that is the reason why men are afraid to do it. They end up manless. They end up with erectile dysfunction. And if they are still in the younger part of life, 60 or thereabouts, it's still a lot of life to live. And you are rendered impotent. What's the hell of being cured and kept from dying, but you have a lowly life after that? Now what is the patient selection for this new Messiah for the treatment of prostate cancer? The patient can be elected to do TULSA if there are no implants, aneurysm clips, pacemakers, because we have to use an MRI, and the patient is in an MRI machine when we are doing it. The patient must be suitable for a minimum type of general anesthetic. The prostate axial diameter must be less than 6 centimeters, and the sagittal diameter less than 5 centimeters. There must be no extracapsular extension or metastases. The tumor should be within 3 millimeters of the urethra or external sphincter. And this is very important, gentlemen, no large calcifications obstructing in the pathway of the intended beam of treatment. And you cannot have a large prostatic cyst in also the treatment path. Now this is the TULSA picture you see when it's being treated. And you can see here, we use it for the whole gland treatment. We can use it for targeted treatment. We can use it for post-radiotherapy salvage. And this is very important. You can use it to treat BPH without a TURP. It can be used for non-cancer treatment as well to shrink the prostate gland. And this very additional, this fact is a very additional benefit for the patient. He's got a large obstructing prostate. Now let's talk about the procedure. Basically, the urologist inserts this treatment catheter. This is called the treatment catheter, and there's a cooling device which is put into the rectum so that the heat generated will take away the heat from damaging other structures. There is an ultrasound, and there is an instrument here called the treatment catheter, which comes out beams of directional ultrasound as opposed to high intensity focused sound. is called directional ultrasound, a new type of ultrasound, not the high intensity focused ultrasound that you heard about in HIFU. By the way, HIFU is obsolete. I was first trained in HIFU in Lyon, Paris by Jallet and Dieu Bernard. And I can tell you that although they were the best center in the world, nobody talks about HIFU anymore. HIFU is out the window. Why? Because of the dreaded rectal prostatofistula. This one doesn't cause that at all. There's a continuous rotational, you see, it rotates around, sweeping, covering the entire prostate. Now, you see, the patient gets into this MRI chamber, and this catheter gets into the urethra and sits next to the prostate. So the treatment is inside out and not outside in, and no danger then occurs with respect to complications. Now, what happened to my? Why is it black in color? This is the one. Now, this is the whole contraption. The patient lies into the MRI chamber. In the separate section behind the glass window, we have this monitor. You can see everything happening, and you can see the beam hitting the prostate and shrinking it and killing the cancer before your very eyes. The two pieces of equipment is basically this treatment catheter and this rectal cooling device. Let's look at the workflow. The urologist, you know, his job is actually quite simple. I must tell you that whenever I do this, I just sit in the next door, I chit-chat with the nurses and I flirt around with them, excuse me for doing so, and have a cup of coffee and talk about old times with the radiologist, and yet can concentrate doing the job. It's so simple. It's a no-brainer. It's easy to earn money, actually. Very easy. You sit up there and have a cracking jokes and doing work. Actually, why do you want to spend 4 hours in the operating room that Professor Chuyen sweating away with the robot? You're crazy. You and I are getting old. We don't want to work so hard. Give it to the young boys to do the radical. We need to relax a bit. You know, we are semi-retired, or nearly so. Now the radiologist is sitting next to you. He's doing all the imaging for you and making sure you don't shoot outside the target. So anything goes wrong, you just blame it. You didn't make sure the beam didn't go there. Blame it. Anyway, the AI of the machine is so good, it will protect it from happening. Anything goes wrong, the AI of the machine will shut it down, and you will never hit anything you don't want to hit. You need an MRI technologist, which is a radiologist, to set up the machine before and after the treatment, positioning the patient, and the anesthetist actually gives a light general anesthetic. The reason no movement is allowed. No movement means the beam will not hit anything you don't want it to hit. Therefore, you do not get any complication. That's the reason for the anesthesia. Now, you can see the whole rigmarole here. That's outside the MRI room here. I think this is the one which we prepare, set up the drip, etc., prepare the patient for the procedure. And in this, the patient's MRI room. And then during the procedure, you can see, here's the temperature of the whole thing being shown up. Here's where you see the area of interest. You mark the area of interest, the region ROI, the region of interest. Actually, it's done by the radiologist. We can just sit there and crack jokes while he's doing it. And there you are. You can see everything being done, and you can see throughout, and you can confirm that indeed the cancer area has been totally ablated at the end of the procedure. Now, someone asked me, can I spend less money to buy this machine? Yes, Professor Chuyen, if any of your machines in this hospital is belonging to this tree, you don't have to buy another MRI. And so the whole setup will only cost us $2.5 million. But if you have to buy a Siemens, another $2.5 million. And if you want the 3T MRI, you have to spend $5 million. But if you have any of these, you don't have to buy, you save $3 million. $3 to $5 million to save. So it's easy to set up. I'm going to conduct a course, a live surgical course of training on people how to operate this machine in Malaysia, Singapore at the end of the year. You're invited to come and attend. You get a certification that you are now licensed to use the machine if you attend. The company from Germany will be the awardee of the award authority to give you the certificate. Now, the important thing about it is that MRI can be used to monitor the temperature. It's called MRI thermometry. It controls the temperature as well as it allows you to select whatever temperature you want at the target point. Now let's look at the evidence for it. Now the FDA pivotal study was conducted, and it was conducted in all these places. And I'm going to show you the results that will tell you that the Messiah has arisen from the dead. There's no more doubt about it, you see. The tomb is empty. Right? I'm going to show you that the tomb is empty very soon. You see, we have now 2 years data to show you that this works. Now, let me show you that we have oncological data up to 5 years here, and it shows you that the PSA, look at the PSA at this point, has remained steady throughout. This is 5 years data, and you can see here the prostate volume after treatment decreases by 92%. Imagine, so you can use it to treat BPH. You can see, when you shoot here, you can see that the gland becomes a small little thing. It shrunk to such a small gland after that. So if you do whole entire prostate treatment, you can shrink the thing and no more BPH. It's especially good for BPH plus cancer patients. Now, if you look at this urinary incontinence, erectile dysfunction, nothing compared to radiotherapy or radical prostatectomy. Radical prostatectomy has a totally unacceptable percentage of erectile dysfunction. I mean, Professor Chuan's patients are probably younger in your country, I think younger. In our country, our men are older men that get cancer. More older men than younger people. But if you have a younger population, you mean the younger people are prepared to have erectile dysfunction, to live life without any erections? I mean, no one will want it, unless if you are a poor man, then you don't care. But if you an average earner in a nearly developed society, they will not accept erectile dysfunction. And incontinence is something that you do not want. I do a lot of classical artificial urinary sphincter, Scott-friendly type of artificial sphincter. So I see all my colleagues send me all the horrible incontinence caused by radical prostatectomy. And I'm the one putting in the artificial sphincter. You don't see, the average urologist doesn't see the bad incontinence. They don't know the patients are suffering. And I can tell you, your life is gone. I have a lawyer right now with permanent suprapubic. It's gone. You see? And he's still practicing law and he's going to wear a suprapubic for life. So you do get bad incontinence. Now here we are, progression-free survival and the context with respect to radical prostatectomy. You see, of course, in any form of focal therapy, there may be some that may need treatment again later. If you select your patients a bit you're too shaky with your selection, some will end up coming back with recurrence, and then you have to do salvage. Now I'll tell you, salvage can be repeat TULSA, can be radiotherapy or radical prostatectomy. No contraindication to go another round. And here you have progression to additional intervention. This is the progression, not very many, but you can see here, there are not too many. But if you need it, you can do it. So it's not a problem. And so you have additional years before you take a chance with radical prostatectomy. Now this is the way it goes, you see, real world experience here to show it to you. If you look at the pictures here, you can see whole gland, nerve sparing, focal ablation, targeted nodule, focal therapy plus enlarged prostate blocking, and you can do a prostate shrinking plus cancer elimination together. And notice that our MRI is so precise that you can spare the ejaculatory ducts and preserving ejaculation. Here you are, radio recurrent. Now, in other words, I've got patients who had radiotherapy and they now come with recurrence. You can use TULSA for them. So it is multiple users capable. Of course, some of them, once they had radiotherapy, they may be prone to stricture formation, and one stricture here is it. But what to do? Your radiotherapy has already caused the potentiality to form a stricture. You can't run away from it. But then you have a salvage procedure that you can use today. And this is the series of patients with recurrent prostate cancer using TULSA. And you can see baseline and 12 months. You see the IPSS score improved, the IEF improved, continence okay, all the parameters are very good, PSA is very good, maintained, you see, at 0.19, very good. And now here we are, the MRI guided TULSA of prostate cancer. You can see here, this is salvage-free percentage. And at the bottom here, you see the potency preservation. Very consistent. This is salvage-free. This is potency-free. Now, some of you will ask me, what is the procedure? Why is it so flexible and so good? You can use it for whole gland ablation. 1.5 hours of whole gland ablation. He walks in, 1.5 hours later he goes out, he stays until afternoon and goes home. That's it. No more hospitalization, no pain, no suffering, no blood loss. Here you have radiation failures, you can use it on focal subtotal gland, or you can get targeted focal, and you get hybrids with low-grade cancer and BPH, or huge BPH glands, and you just use it for BPH without cancer. These are the indications. And we subdivide them as GG1, 2, 3, and 4, and so forth. This is a bit more detailed, so I don't have much time. I'm going to skip this to show you that this is the CAPTAIN study showing the 1 year efficacy and 3 years efficacy. Showing you is excellent, and this study will be extended to a 10-year study and it's ongoing right now. Now the people running this CAPTAIN study are the pioneers of TULSA, of which one of them is Joseph Chin from Canada. Now Joseph is coming to see our center in our part of the world in October. I arranged for him to come. So those of you who want to hear him talk about it, he's a pioneer. He'll be in Singapore, I think, in October, addressing this same subject. Because he's a pioneer who helped develop it together with Clothes in Canada. They are the king of TULSA. And they have created an international customized ablation registry of which we have signed on. Now, case studies are plentiful, but I will show you 2 of my own cases to make the impact. I can show you this, all the world studies, and no point showing other people's work, so I will not. But you can see when you are treating, you see the hands of a clock moving, and it moves until in a 360 way until it covers the whole gland, and you get the whole gland ablation. Can you see? The red thing is the intensity of the temperature, and when it covers the whole circle of the watch, you have completed whole gland ablation. If you look down here, the color of the MRI turns black, meaning it's all gone. The tissues are all killed, so to speak. Again, I won't show you so much of this. I'll just show you that this is a median lobe can disappear for an enlarged prostate gland. And sitting behind the screen is what you see. It's very interesting, you see, you're enjoying yourself watching this. I want to show you too many of those pictures because what you need to show you how it actually works. Here is a video of the procedure. The patient is in the MRI chamber and the catheter is put in, and you can see sagittally or plane by plane it shoots in, knocking off the cancer in a around the clock 360-degree manner. You can see the progression real time on the MRI actually. The thermometry function of MRI controls the temperature, allow you to see as well as to control whatever temperature you want at whatever spot of the gland. What are the key advantages? Preserving erectile function, preserving continence. PSA, you see, is well maintained. I want to always emphasize this. Let me show you my first patient I treated in December 2021. That's him, the patient. He's a lawyer actually. And he refuses to have a radical prostatectomy, Professor Ong, because he's midlife, youngish, just remarried because his first wife died of breast cancer. So now he's got a new wife, and suddenly he found to have cancer. He ain't going to become impotent because he will wreck his second marriage. So he wanted something more guaranteed of sexual preservation. So he insisted on this. So at that time, our machine was not available. I went with him to the center where I trained in Turku University in Finland, actually. And down there, we did it. The next day, we checked out and we went direct to the airport. Now, he had a Gleason 4+3, grade 3 random biopsies throughout the rest of the gland, no other areas positive. And the tumor was mainly in the posterior part of the prostate, about 1 centimeter in diameter. This is the fusion MRI biopsy. Now, the day before the treatment, we do a scout MRI of the prostate, again to verify. I know the time is running, that's why I'm rushing. So you need a bit of preparation because you can have air. You cannot have air in the rectum. It will disrupt the beam. So we use this stuff to get rid of the air in the colon before it turns up for the procedure. This is the rectal probe. This is the catheter with the tip, coude tip, and you need this coolant to run in through to keep the end cool. And this is what you see in the opposite room. And you can see the tumor here. It's a posterior tumor, quite near the rectum, but we are not afraid because we won't touch the rectum. And you can see again the tumor is quite close to the rectum at the back here. And you see everything. Now this is, the next day I was on the train to the Turku International, Helsinki International Airport with him, having breakfast on the train and flying back the next morning of the procedure. Now after the procedure you have to keep him in the recovery room, and since he was traveling to avoid retention of the urine, we use a temporary SP. Results were very good, as you can see. Later on, 4 months later, we did the MRI, no tumor seen. And this is the re-biopsy I did in 1 year to prove the point that there's no tumor at all. This is a repeat MRI, multi-parametric biopsy. So I will not go over that too much. This is a second patient, and giving you somewhat the same type of story. So because I have no time, I'm not going to go over. There was his MRI. So ladies and gentlemen, this is the the results of the 13 institutions study, which has already proven what I've said to you, and I have no time to go into detail their results, but basically, almost zero impotence, almost zero incontinence, and I will have this last message to say to you, non-believers. Now, if you do not believe, all of you are going to be sent to hell. You, sir, hell is awaiting thee. Should thou not listen to my words of wisdom from on high? Now, if you don't believe in divine messages, I'll give you a message from Dr. Leonard Sweet. Mr. Chairman, Mr. Co-Chairman, I end with these words, my presentation. What you do, ladies and gentlemen, is your history. Radical prostatectomy, whatever you have done is your history. What you now set in motion will be our new legacy. So if you do not follow what I say today unto thee, brethren, thou shalt have no legacy. Thank you very much.
Thanks, Peter. Thanks a lot.